My name is Dele Ogunsetan. For those who are new today to our seminar series, and I am delighted to welcome you. This is a continuation of what I consider one of the best set of seminars that we have hosted in a while, and it is on a very timely topic. But before I introduce our speaker, I just want to pay attention to certain housekeeping rules. So this room is very well designed acoustically, which means every sound carries. So if you're tapping on your computer or have to change seats, please do so quietly. I also would like to acknowledge the support of the Office of Continuing Education here called UC Extension for helping us videotape our seminar series. And these seminars are available through the open courseware site of the campus. It takes about 2-3 weeks before they show up there. And also to thank all our speakers for agreeing to do this. It's a way to reach a broad audience, and our seminars are really viewed all over the world, at least as far as the people who click on the download button and the view button shows. It's a very, very popular series. I also like to invite you to the lunch that we host after the seminar to meet the speakers and follow up with discussions and questions and opportunities for networking. So those lunches take place at the public health offices and either instruction and research building, ARB, which is just about 5 minutes walk from here. So this is, I looked, I think yesterday, it may not be current, but the current flu epidemic, I think something like 37 children have died, and many people have been sickened, and it's all over the 50 states of the US. But today we'll get an what the current status is. We didn't plan this seminar for today because the epidemic will be right now, but we usually do this a year in advance, so this is quite timely. Dr. Michelle Cheung is the Deputy Medical Director of Epidemiology at the Orange County Healthcare Agency. And she's been doing this work for a long time. She's hosted some of our students in their public health practicum. And it's a really distinguished opportunity that we have to interact with county officials so closely at UC Irvine. She does physician education, and she provides clinical and epidemiological expertise for communicable disease surveillance, outbreak investigations, and public health emergency preparedness. Before she came to Orange County in 2004, she worked as a hospital-based pediatric infectious diseases consultant, and also she assisted with influenza surveillance at the state level. She's board certified in pediatric infectious diseases and pediatrics, and she completed her pediatrics infectious disease fellowship at UC San Francisco and a preventive medicine residency at UC Berkeley, UC San Francisco Collaborative. She also did a residency in pediatrics here at UC Irvine. She got her MD from Jefferson Medical College in Pennsylvania, and then her master's in public health from UC Berkeley after she got her Bachelor's of Arts from Princeton. Please join me to welcome Dr. Michelle Cheung to UC Irvine Public Health.
Sorry? Are there controls? Do I just use the keyboard for controls?
Yeah.
Okay. So it's really a pleasure to be here and to see so many people to come. Can I just get a sense of how many people are undergraduate students? All right, graduate students and faculty. Great. and staff. Okay, so my original topic was supposed to be influenza surveillance in California, but really the data from California feeds so much into the US data, and there's a lot of overlap that I'm also going to present the overall United States surveillance data as well, so you can get a picture of where California fits in and what's going on nationally. So I want to start first with a case, just so you understand what influenza, how important it is, and how severe it can be, and how healthy, normal people can be very sick and have serious sequelae. So this female, 27-year-old, she was 36 weeks pregnant. This was her 5th pregnancy. She already had 2 live children at home. She had no past medical history except for she smoked, and she was obese. Back in May of 2009, during our 2009 H1N1 pandemic, she had onset of fever, cough, and chills for 2 days. And she was admitted to the hospital from a clinic for upper respiratory infection symptoms and given antibiotics in the hospital. Her chest x-ray did not show any pneumonia. And she was transferred to the intensive care unit for low blood pressure, ended up being intubated, so had to be on a ventilator to be able to breathe, and had an emergency C-section in the intensive care unit on the 3rd day of hospitalization, and it was in septic shock. She developed diffuse pneumonia, had adult respiratory distress syndrome, developed a bleeding disorder with low platelets and multi-system organ failure. They did test the fluid from her bronchial, did a wash and got fluid out from her respiratory system, and on the 4th day of hospitalization, and sent it for culture, and they did grow influenza A, but the result wasn't ready for 15 days. So she was started on an antiviral for influenza on about hospital day 19. And then we did, in our laboratory, public health laboratory, we did confirm that it was the pandemic 2009 H1N1 strain. And the patient died on hospital day 44 from respiratory failure, secondary to viral pneumonia, secondary to the novel H1. So influenza, as you can see, can be a very serious disease, but it is not a reportable disease for each case. It does cause, of course, substantial morbidity and mortality. They updated the death estimates in 2010. Previously, people would say about 36,000 deaths, over 200,000 hospitalizations. But when they went back and looked at estimates between 1976 and 2007, they made a bigger range, because really it's not just influenza-confirmed deaths. There are a lot of conditions that get exacerbated by getting sick with influenza. So the upper estimate is it can range from about 3,000 to 48,000. And then if you include just the pneumonia and flu deaths, then it's just about 1,000 to 14,000. And about 90% of these influenza-related deaths are in people over 65. As I mentioned before, there's over 200,000 hospitalizations a year usually, but there is a wide range. About half of those are in the elderly. But the risk for hospitalization in young children is very similar to the elderly, and that's something that over the last decade is relatively new, that they discovered that young children are at equal risk to the elderly for complications from influenza. About 2.5% to 20% of the population become ill. The highest rates are in children, and there can be attack rates over 30% in children sometimes. And of course, this causes substantial economic impact. This was back several years ago, so it's probably more money now if you do the estimate, but back it said $87.1 billion were estimated the cost of flu every year in the US. And just to show you, this is data from the CDC. The green are the percentage of pediatric patients, so children with influenza that have underlying medical diseases. I don't mean for you to see all the lines. The blue is the adults, but really, if at the bottom there, that's no known condition. So even healthy people are getting, about half of the kids who get influenza and get hospitalized are healthy, and about almost 10% of the adults as well. So my objectives today are to briefly go over the basics of influenza, just so everyone has some background information, and then present an overview of seasonal influenza surveillance at the local level, the state, and the global level. and then also talk a little bit about our enhanced surveillance that we do. So this is an influenza virus. It's an RNA virus. I just want to point out a couple things on here. So the things my pointer doesn't work, but the things we talk about the most, you hear about H's and N's, so H3N2, H1N1. So the H is the hemagglutinin. It's an antigen on the surface, and that's the one that's in the vaccine. So when you have your flu vaccine right now, there's 3 strains. It has antigens from the hemagglutinin antigen from 3 different strains of influenza. And then the hemagglutinin is what helps with binding of the virus to the target cell and with entry into the cell. The N that you hear about with the H5N1, H1N1, that's neuraminidase. And that's another surface protein there. It helps with viral penetration and release, and also contributes to how severe or how virulent the infection might be with that strain. And when you hear about the drugs like Tamiflu or oseltamivir and Relenza, which is a namivir, those are neuraminidase inhibitors, so that's the target there of those drugs. And then the only other one I want to mention is that M2 protein, which is an ion channel involved with replication, and that's only found on influenza A viruses. So this is another picture of the influenza virus, and you can see close up what those antigens look like, and then by electron microscopy as well. So there are 3 types of influenza, but really we just hear about 2, A and B, but there's also type C. So type A is the one we hear probably the most about, because this one is the one that can cause illnesses in all different animals and in humans. So in animals, it can cause illnesses in birds, and actually birds are considered the reservoir for the influenza A viruses. Swine, horses, they can all get influenza A, as well as other animals. And it causes moderate to severe illness in humans. It can affect all age groups, and it changes frequently. And so it's constantly changing. This is the one that's subtyped based on the hemagglutinin, the H, and the neuraminidase, the N. And all subtypes of type A can infect birds. Just H1 and H3 affect pigs. So when you see those long names sometimes, the first letter is the influenza type, A or B. Then you see the geographic source. So this is actually the pandemic H1N1 strain. It was found, it was isolated first in a laboratory in California, so it's called AA California. And then the next number is the isolate number, and then the year of isolation, and then you have your hemagglutinin, your H's, and your neuraminidase, your N's. So as I mentioned before, influenza A viruses all start with the birds. That's the reservoir. And then from the birds, they can go to different animals and then to humans as well. So influenza type B, that usually causes less severe illness, but it can cause deaths and hospitalizations as well. It affects only humans, not animals, and primarily children, but once again, adults can get infected as well. It's not subtyped, so you'll never see like a H5N1 or something like that with a B. Just the A's have the subtypes. And there's 2 lineages, the Victoria lineage and the Yamagata lineage, and that really plays a role because right now our vaccines only have one of those lineages, and it's a guessing game every year to try to make sure the right lineage is in the vaccine, and if we guess wrong, then the vaccine doesn't protect against the circulating strain that year if it's the other lineage of B. And then C is the one that you probably never hear about. It causes a common cold syndrome, usually not that severe, although there have been hospitalizations with C as well in places that actually do studies to test for it. It can infect pigs, and it's not involved in any epidemics. So human influenza is what I'm going to be talking about today, and that's a highly transmissible respiratory illness caused by influenza H1 or H3. Usually you have an abrupt onset of symptoms, fever, chills, muscle aches, cough, runny nose, sore throat. Usually it's self-limited and gets better by itself, but symptoms can persist for 1 to 2 weeks. And every year we have epidemics of seasonal influenza. And sometimes they call it interpandemic influenza as well. And then very rarely we have sporadic, unpredictable pandemics, and I'll talk more about that to tell you the difference later. So just so we can see here, we've all had flu. I'm sure some of you probably already had it this season. My boss has it right now. So fever, runny nose, cough and sneezing, and feeling pretty nasty. We have here, you have a particularly nasty case of the flu, Mr. Jones. So the reason why we have influenza epidemics every year is that the virus changes all the time. So this is, again, the influenza virus. And here you have the surface proteins, the hemagglutinins and the neuraminases. And these Y here, that depicts an antibody. So you get influenza one year, your body develops antibodies to these proteins here. But then, shown in pink here, the virus changes just slightly so that you may have a little bit of protection, but you still can get infected, you still can get sick from influenza. Even the virus has just changed a little bit, and they're changing constantly. So this is called drift, and this is why we have annual epidemics of seasonal flu, and this is why you can get flu every single year. So this is how flu is transmitted. This is someone sneezing. You can see all those particles.
Can you say something? Oh, maybe that's what you. The seasonal issue is troublesome to me because even in hot climate regions, it's the same time of the year. It's once a year you get.
Right, but it's, you know, the southern hemisphere, it's their winter in the summer, and that's when they have their peak of flu season. So, I mean, I think it's part of it is the close environment. People are staying indoors, a lot of contact. That probably helps with the transmission as well. It was very unusual that year that we had the H1N1 in the summer because usually we don't have outbreaks of influenza in the summer. So it is person to person, mainly through large respiratory droplets, although they think now that there may be an airborne component as well. So, and then also from direct contact with the respiratory secretion. So, you know, someone sneezes on the table, if you touch it and touch your mouth, your nose, that can spread like that as well. So incubation period is usually 1 to 4 days, so from when you get infected until you develop symptoms. And then you're infectious from 1 day before symptoms to about 5 days after your symptoms start. It can be longer in children and in immunocompromised people. And just to show you how influenza is transmitted. So really, people think it all starts with a school child. They infect who's never had flu before and gets sick. They spread it to more kids at school, and then to their family, and from their family members to the other people in the community, including those high-risk people. And just to show you, this is my son. All that nice shiny, he's much older now. Some of you know him. But all that shiny stuff on his face is snot. And he loves to put his fingers in his mouth and then share his germs with other people. And then my daughter, in a much nicer way, also shares her germs with the elderly and high-risk people as well. So why schools are such, school children in schools are thought to be the mixing ground. This is basically a house. It's based on an average 2,600 square foot house, so not really a house that most of us would have in Orange County, but here we have a family of 4. So this is how much room you would potentially have in your house, but at school, this is how crowded they are. So a lot of mixing, the kids have poor hygiene, and they're cooped up together, and their immune system, they're more susceptible to infection as well. So this is why in some countries they've seen that vaccination of all school children affects pneumonia and influenza mortality in general in the whole community. So this is in Japan. So way back when, they had a lot of influenza and pneumonia deaths, and then they started in 1962 to vaccinate the school children, and you can see the deaths and the all-cause deaths all dropped. And then in 1977, it became mandatory, the school vaccination. And then in 1987, the parents were allowed to refuse vaccination, and then you see that the deaths increase. So this is kind of why our vaccination recommendations, even in the US, have changed over time. So before 2000, it was really the high-risk persons, the elderly, people with chronic medical conditions, pregnant women, and then household contacts of these high-risk people who were recommended to get vaccinated. Then they realized that they should drop it to adults 50 and older, and then they, as I mentioned before, there were studies that showed the very young children were at increased risk, so then they started vaccinating them. But what it was eventually moving to is, in 2008, all children were recommended to get vaccinated, and now, since 2010, all people 6 months and older are recommended to get vaccinated every year. So this is our vaccine, how it's made right now, with eggs. So they grow the virus in chicken eggs. It takes a lot of eggs. It's a very crude system. Right now, there's 3 strains, 2 type A's, one H1N1 and one H3N2, and one type B. And it's a very long process. They have to decide basically now what strains are going to be in next year's vaccine, because they have to grow the viruses and make all the concentrates and do all the packaging and testing in order for it to be distributed in the fall. So the reason why I say now is there's actually just FDA-approved cell culture-based vaccine. So that may be available, that should be available for next season, as well as quadrivalent vaccine. So I mentioned 3 strains are in the current vaccine, 2 type A's and 1 B. So next year there'll be 2 B's as well. So each lineage will be represented in the vaccine. So all of this information I'm giving you so you can understand why our surveillance is so important. So because in order to prevent or control influenza, we have to know what strains to put in the vaccine. So that surveillance plays a big role in that. The other things that help to control influenza is, covering your cough, using hand hygiene, contact avoidance, staying home when ill. But all of these recommendations that we start making is once we hear that through our surveillance that there's influenza in the community, schools report to us increases in influenza-like illness. We provide them letters to send home to their parents, send home to the parents and the children. And then for some as well, antivirals medicines are recommended, but we need the surveillance to be able to see if there's resistance to those medications. And so here we have, I hate it when we're not sure we're inoculating against the right strain of the flu virus. So without surveillance, the vaccine would be just a guess every year. But with our surveillance, it's at least an educated guess. We're sometimes wrong, but we try to get the most likely strain to be in the vaccine. So the goals of influenza surveillance, first of all, it's not meant to capture all cases. So when you hear numbers, that's not all the cases of flu. That's also, even when you hear about the deaths, there's deaths that people didn't test for flu, that didn't get reported. So really, it's just a snapshot of what might be out there. So you kind of see trends when it comes into an area, what strains might be circulating, but it's not supposed to be population-based or have the actual definite number of cases. But it does provide information about influenza transmission to allow policymakers to better prepare for the season and for making recommendations to the public. It helps to inform the selection of influenza strains for the upcoming vaccine. It provides data for decision-making in terms of recommendations for vaccination and treatment with antivirals. And it also helps describe critical epidemiologic features, what risk groups are at increased risk for complications, what kind of transmission characteristics and impact the viruses that are circulating this season might have. And then it helps us to monitor what's going on globally. The viruses that we have, what country were they first at, how much have they changed, are there new strains coming out, is a pandemic likely to occur when there's a novel strain? And so we also use the surveillance to monitor for these novel strains and possible pandemics. So in order to have our influenza surveillance, we rely on the laboratory testing. So really for influenza, the laboratory testing available that the clinicians use, there's polymerase chain reaction, or PCR, rapid influenza tests, which test for the antigen, and also DFAs or IFAs, which are direct or indirect fluorescent assays. But these can have false negatives, so clinically, the physicians have to use their judgment when interpreting the test. We use these test results for our surveillance to see what's circulating. And then there's also viral culture, and then the shell vial culture, which is called R-mix, which also tests for other viruses as well. So in California, we have a very robust influenza surveillance system that's been around for a while and is really a model for other areas. There's an article in the American Journal of Preventive Medicine from 2007 if you want to see a little bit more detail about how the surveillance system is set up. And then also on the California Department of Health website, you can see all the different aspects of the influenza surveillance there. This surveillance in California has been going on since at least 1998 in collaboration with the Centers for Disease Control and also Kaiser Permanente. And now it's also a collaboration with all the local health departments, Sentinel Providers, who are physicians, nurse practitioners, and physician assistants that are out in the community, and also laboratories. So just to get a snapshot, this is from that article I mentioned in the American Journal of Preventive Medicine. The idea, again, this is not population-based, but it's meant to tell you the trends and the magnitude of the season. So here they have, in the white, the flu admits for Northern California Kaiser. In the yellow squares, it's Southern California Kaiser. In the blue, it's influenza-like illness in outpatients. And then here in the green, there's school clinic influenza-like illness. And then antivirals from Kaiser. And then laboratory detections in this purplish color. And then the bottom there is severe pediatric influenza cases. So the way influenza surveillance is looked at is they start with week 40. So, there's 52 weeks in a year. Week 40 is the beginning of October, and that's when traditional flu season is set to start. And then it goes on to week 20 of the next year, which is in May. And so that's usually how we see most of the graphs for influenza. So this is from the region 9 of the country. It's broken up into several regions. Region 9 has California, Arizona, Nevada, Hawaii, and Guam. So this shows you, for the last 3 weeks, what types we're seeing. So the red is influenza A H3. The orange is influenza A H1, the 2009 H1N1 strain. And then the yellow are A's that were not subtyped. And then the green are B's. So really the majority of what we're seeing is influenza A. And then when you can see that there's differences depending on where you are in the United States. So these are the different regions. And here you see the amount of red here. The AH3 is less in other areas. Here they see more of the, less are subtyped, and they're seeing a little bit more B in other areas of the country. And then here is over time, starting once again with week 40, October. This is region 9, all of California, Nevada, Hawaii, and Arizona and Guam as well. So week 52 is the end of the year between Christmas and New Year's, and it peaked in week 1, the first week of the year, and seems like it is decreasing, although locally we're right now in Orange County seeing an increase still. So the laboratory surveillance in California takes data from hospital, academic, and private and public health laboratories. And every week, these laboratories report on the number of lab-confirmed influenza and other respiratory virus detections. And then there's also other data coming in from the Respiratory Laboratory Network in California, as well as California Sentinel Laboratories, and the State Viral and Rickettsial Disease Laboratory, and I'll talk more about each of those. So the California Respiratory Laboratory Network is 28 local public health laboratories, including our Orange County laboratory. And these laboratories all report the preliminary chain reaction PCR results for influenza A and B. Some of the laboratories also have the capability to report RMIX, which is 5 respiratory viruses, influenza A and B, RSV, parainfluenza 1, 2, and 3, and adenovirus. And what they use is a shell vial culture for that. So we do get some data from that for that as well. And then there is listed all the county public health laboratories that participate in the Respiratory Laboratory Network. And then the California Sentinel Laboratories, which also contribute data, that's a network of clinical, commercial, academic, and hospital laboratories throughout California. They also report weekly on the number of laboratory confirmed influenza and other respiratory virus detections. And their results come from rapid tests, DFAs, viral culture, and preliminary chain reaction results. And they include a lot of the hospital laboratories, Kaiser Permanente, both Northern and Southern California regional laboratories, some of the bigger centers like Stanford Medical Center, UCSF, Children's Oakland, and around here, Children's LA, UCLA Medical Center, and in San Diego as well. And then the state has its own virus lab. And they're the reference lab for the state of California. So in Orange County, when we have a question on one of our test results, or if we want further testing, we send it to the state. They also, people send a fraction of their isolates for antigenic and genetic characterization, because we don't do that locally in the county. And then the Sentinel Providers, which are those outpatient providers I'll talk more about, they actually send specimens directly to the state for testing on their patients with influenza-like illness. Here in Orange County, our Sentinel Providers send them to us because we have the capability to do the testing, but a lot of the counties don't, so they send it directly to the state. They also do some limited antiviral resistance testing, and they also work very closely with the CDC to develop new assays. So this is the summary of the laboratory detections in California from 2007 to 2013. This is our current year here in red. And then just to show you some of the big previous years, this was our H1N1 year. You can see that we had a lot in the summer there. And then this other year, that's the brown year, is 2010 here too. Oh, and sorry, the green one here is 2008 was a big year as well, this little tiny green line. And then this is Orange County data from this year, just to show you that we do this here too. So in Orange County, we get reports from the hospital laboratories, and we also have Sentinel Providers. We have 18 in Orange County that send us specimens on patients with influenza-like illness. And so this is what we're seeing so far. We're still getting a lot of reports, and this will likely get more after the data from early this week comes in. So the blue are influenza A, and then the yellow are influenza B, and then the tiny little green there are the ones that the test doesn't specify A or B, it's AB unspecified. And this is showing Orange County compared to previous years. The current year is here in the gray, and then some of the other big years, 2003, 2004 was a big year. 07, 08 here in the blue, and then this brown was 2010, 2011 here. So I mentioned Sentinel Providers a lot. This is a mainstay of CDC's and the state and our local surveillance. So these are physicians, nurse practitioners, and physician assistants. And your UCI Student Health, who's sitting up here, they participate as well. They're one of our Sentinel Providers. So every week they report on the number of patients that they see with influenza-like illness. And so the definition for influenza-like illness is a temperature of at least 100 degrees Fahrenheit or 37.8 degrees Celsius, and cough, and or sore throat in the absence of other known cause. So they report all those cases, the number of all those cases every week, and then all the patients they saw for any reason, so we can get a % of total visits for influenza-like illness. In California, there's over 150 Sentinel Providers. The goal for CDC is 1 per 250,000. So I mentioned in Orange County we have 18. Our goal with a population of 3 million would be about 12. So we have quite a few Sentinel Providers here in Orange County. And then the Sentinel Providers also are invited to submit specimens on their patients with influenza-like illness that we test in our laboratory for influenza and other viruses. So I already mentioned the definition, and really well, they can tell you the truth of how long it takes, but we're told it only takes about 10 to 30 minutes a week. There's like some people use these check boxes where they can mark off when they see a patient with influenza-like illness, and then at the end of each day they mark the total number. A lot of places have gone electronic and can pull this out very easily electronically. And this shows you how this is all summarized at the state level. So they make a seasonal baseline using a regression model from the data from the previous 7 years, and then they make so that's this this dotted line here, and this is the different seasons. This is different years, 2008, 2009, and then every different season here, and this is the current season right now. So that dotted line is the seasonal baseline. And then the epidemic threshold, which is the top line, is 2 standard deviations above the seasonal baseline. So you can see what years seem to be a bad year when there's a lot of influenza-like illness. Right now, here we are above the epidemic threshold, but not as much as we've seen in the past years. It was more than last year, but we've had worse years for influenza before. And just to show you for the whole region, once again, this is region 9, they are seeing a decrease, although we're not locally in Orange County quite seeing that decrease right now yet. So the other data that's on hospitalizations we get from Kaiser. So both Kaiser Permanente Northern California and Kaiser Permanente Southern California, which are completely separate entities, they contribute data to our to the state's project. Because Kaiser insures over 6 million people, that's considered a sixth of the population and thought to be a good representation of what's going on in the state. So they look at the inpatient diagnoses for keywords for flu, influenza, and pneumonia, or variants of these words, and that's what's defined as the pneumonia and influenza admits. And then they take as the denominator the total number of admits, excluding pregnancy, outpatient procedures, labor and delivery, and birth. They also look at Kaiser data for their usage of antivirals, so the influenza antivirals, Tamiflu, and Relenza. And this look is showing you the Kaiser Permanente Northern California data between 2008 to 2013. They developed their model, the seasonal baselines, based on the data from the past 5 years. And once again, the epidemic threshold is the 2 standard deviations above. So you can see again, we're just right now just a tiny bit over that. So some other details for California surveillance. As I mentioned, they do test some strains for antiviral resistance. So far, they've tested 12, and all of them have not had any antiviral resistance. They send some strains to the CDC for strain typing to see if they match the vaccine, and so far only 3 have been tested from California, many more, which I'll show you from the US, and all 3 do match components of the vaccine. They also, since 2010, have been they made influenza deaths in persons 0 to 64 years of age reportable, so we do get that data now as well. So in California, there's been 9 deaths this season in persons 0 to 64 years of age. They also have severe cases that are in the ICU, intensive care unit. That's voluntary reporting. That's not mandated like the deaths are. They also monitor outbreaks. So far this season, 11 outbreaks of influenza-like illness have been reported to them. In congregate living facilities, all of them are influenza A. And once again, all this data is under reporting, it's not population-based, and so there's more influenza out there than the numbers I'm giving you. And then a little more details, similarly for Orange County, locally about 82% of the flu that we've tested through our surveillance is type A. Of the A's that were subtyped, 93% were H3. We've had 16 severe cases. So a severe case is a person who was in the intensive care unit or died, who are between the ages 0 to 64 years of age and thought to be associated with influenza. And that 16 includes 6 children and includes 4 deaths. We've also had several reports daily of influenza-like illness outbreaks and increases in absenteeism from schools as well as long-term care facilities. And the other thing that California does, which we don't have data for this season yet because they usually summarize it later in the season, is similar to that table, the graph I showed you early on. They looked at underlying conditions. This is last year, the whole season, the data, to see what underlying conditions that people who are hospitalized with influenza have. And once again, to show you here, the green with the kids, almost 40% of the kids had no underlying condition. They were still hospitalized with influenza, and 16% of adults. And just some of the other things that are considered risk factors, heart disease, about 21% of the kids and a third of the adults that were hospitalized with influenza last season had heart disease. Lung disease was more, so about half of the adults. Metabolic disease includes diabetes as a risk factor too, so quite a few of the adults had that, about 30% there. And then immune suppression and neurologic disorders, pregnancy. And here, obesity, that's a body mass index over 30 and over, about a quarter of the hospitalizations for influenza in adults had obesity. So now going on to the national data. So all of our California data that I mentioned goes into the national data. This is the CDC, from the CDC website, and they have laboratory data from 85 World Health Organization laboratories, which are in the United States, as well as 60 national respiratory and enteric virus laboratories. And that includes state public health laboratories, some large academic centers as well. So the red here is the influenza A H3s. The yellow is A's that weren't subtyped. The orange, which you can barely see, are the H1N1s. And then down here, the greens are the B. And this is, again, starting in October up to where we are last week, January 19th. And then here is the % positive. So nationally, it is coming down, but in different regions, such as in Orange County in California, there's still elevated numbers and increases. And just to show you, for the last 3 weeks for the whole nation, about half, a little more than half were H3, and then this again is the Bs here, the H1s, and the untyped ones there. So when you look at strain typing, now they're looking specifically to see if the strains are matching the vaccine. They don't test all of them, but just a subset. So since the season started in October, of the H1N1s they tested, all of them were the strain that's in the vaccine, so that's a good match, of course. Of the influenza A H3N2s, only 2 were not a match. So basically 100% were matched of the influenza H3s to the vaccine. And then influenza B, I told you before, there's 2 lineages, the Victoria and the Yamagata. The Yamagata is the one that's in the vaccine this year. So about 70% of the Bs circulating match the Yamagata. So the other 30% do not. But once again, the Bs are really a minority of the flu circulating. So overall, the influenza strains circulating do match what's in the vaccine. So there should be good coverage. And then as far as resistance, antiviral resistance is very important because, of course, it affects our treatment. There used to be more drugs that we used for influenza, amantadine and rimantadine. Just even since I've been working at the county, those were used for influenza A, but all the strains circulating are resistant now. So we don't even talk about those drugs anymore. So the only ones available are oseltamivir, which is Tamiflu, and zanamivir, which is Relenza, the inhaled one. So of all the influenza A's that were tested so far this year, of H3N2, none of them are resistant nationally. Of the B's, again, none of them are resistant. And of the H1N1s, just 1 so far has been resistant. And periodically there are a few resistant specimens, but it doesn't seem to be that those viruses are spreading or causing outbreaks or anything like that. The other thing that the CDC looks at is mortality from pneumonia and influenza. So there's 122 cities, and they report on deaths which have influenza as a cause of death or pneumonia. And then once again, they have a regression model using the previous 5 years to come up with a seasonal baseline. And their epidemic threshold is 1.645 standard deviations above the seasonal baseline. So you can see this year, this is the highest we've been for a while at 9.8% with the week ending January 19th. So it was worse than last year, a little bit more than here. And then back in 2008, it seems like it's about comparable to the year we had there, 2007, 2008. And then we mentioned before pediatric deaths, so that's monitored since about 2003, 2004 season. CDC's been monitoring deaths in children. And this year, here we are. We have had some pediatric deaths nationally, not as bad as in 2009, 2010, but there are definitely deaths. And if you look at it a little closer, the red is influenza A and the green is influenza B. So you can see both influenza A and B are causing deaths in children. This is, just to remind you, the 2009 H1N1 pandemic, which was all influenza A then, that was causing the deaths pretty much. Then the other data that the CDC follows is hospitalizations. These are laboratory-confirmed influenza hospitalizations, and they break it up by age group. And this data is from 80 counties in 10 states that participate in the Emerging Infections Program, as well as another 5 states. So the top line there is adults 65 and older. So those are the ones that are really getting hit hard right now with influenza hospitalizations. And that's typical of seasons that have H3 strains predominating. The next line there is the 0 to 4-year-olds. So they're the next highest risk. And then the purple is the pink is the 50 to 64-year-olds here. And just to compare that to previous seasons, these are hospitalizations this year, and then last year it was pretty mild, the year before, so it's about the same as it was back in the 2009 year there, the magnitude of the hospitalizations. And comparing it further back to 2007, 2008 was considered to be a bad year, but they were just starting to collect the data then, so that may be part of the discrepancy of why there weren't that many hospitalizations there compared to this year here. And the other thing people always talk about is age. So I mentioned that this year's hitting the elderly a lot. These are hospitalizations again. So the top is green is the 65 and older, and then the pink is the 50 to 64-year-olds, the purple is the 18 to 49-year-olds, the orange is the 5 to 17-year-olds, and then the green is the 0 to 4-year-olds. So I just want to draw your attention to the big difference here that what we saw during the H1N1 pandemic. Note, elderly weren't barely affected then because they must have had some cross-reacting antibody from before, from a previous infection they had. Really, the younger adults and the children were hit much harder back then. So this was, I showed you for the past season. Now this is currently, so far about 40% of children don't have any underlying condition, and then who are hospitalized with influenza, and for adults it's 7.4%. So that's the current data right now. And then overall for influenza-like illness, this is the season here from the Sentinel Providers. Nationally, there's about there's a couple thousand Sentinel Providers nationally. About 1,800 report every year. So this is influenza-like illness. So nationally, it's come down, but once again, locally, it hasn't. And just comparing to other years, the 2009 to 2010 pandemic year here, the purple is the 2003-2004 year, which was pretty bad. And then the blue is the 2007-2008 year. And just in terms of timing, too, I mean, some people think that this year came very early, so compared to these years here, it did. The other thing that gets reported is the state and territorial epidemiologists report on geographic activity. So either no activity, sporadic, which means they do detect flu, but there's not a lot of outbreaks. Local, there may be some outbreaks. Regional, there's outbreaks in at least 2 regions, but not half of the regions of the state, and widespread, over half the regions of the state have outbreaks. And so right now, we're widespread pretty much throughout the US. And then the other thing is that they report on is influenza-like illness activity compared to times when there's no influenza-like illness. Right now, California is orange, which is moderate. A lot of places are still high in the red there. So all this contributes also to the global surveillance. I just want to mention here, as I mentioned before, the Southern Hemisphere has their flu season in the summer. So right now, they are, the lightest color is 0 to 10% influenza positive, so really no flu in the Southern Hemisphere in terms of South America and some other areas. But we're up here over 30% in the Northern Hemisphere. And then also the breakdown of influenza types is different. Here the Bs are the red, so we really have mainly As, hardly any Bs, but then in some other areas, like here, it's mainly Bs. So really, things are different. It's very regional, what influenza that you're seeing. And the other thing, just to show you, I mentioned how much flu virus has changed. This isn't so that you can actually see the picture, but this is a genealogic tree of influenza viruses, and the color is where each dot is a different virus that was tracked, and then the color is where they originated, so you can see that they move from area to area along a line, and that they change constantly. And this is just from 1998 to 2008, the H3N2 viruses that have changed so much. So going back to this CDC graph, I want to talk now about enhanced surveillance. So this was the 2011-2012 season, and I mentioned the reds were H3s, the greens were blues, the oranges were H1s. So during the summer, there started to be these little purple colored ones, and that was the variant H3N2. So once again, similar to when we had the H1N1 pandemic, it's unusual to see an increase in flu in the summer, and then when the laboratories were unable to subtype them, they sent them to the CDC, and they found that this was a new virus that was previously not seen in humans. So influenza A viruses, all of the subtypes can be seen in birds here, and then some of them can be seen in humans and swine, but really, once again, the birds see all of them. That's where they all originate. So previously, we used to talk about H5N1, and it's still going on. We don't hear so much about it, but with poultry and in different countries, this is the current status here. The red are the countries that are still having a lot of cases. But there's still cases going on. There's still poultry outbreaks. And we do have enhanced surveillance. So if we do have a person who has influenza that said they traveled to one of the affected areas, we will have our laboratory conduct specialized testing if it doesn't type with the regular primers that they have in our laboratory. So our enhanced surveillance that we do, the severe ICU cases, that's not required, but we do monitor all the people in the intensive care that are under 65 with influenza. We do look at emergency room diversion hours. So if an emergency room is closed because they're full, that's all monitored, and that sometimes shows when there's increases of influenza or activity. And then 911 call data, we're starting to look more at. And I mentioned we do the enhanced surveillance for H5N1. And then to use the 2009 pandemic as an example, when that virus was first detected, the priority surveillance changed so quickly over time because we didn't know what we were dealing with. First, we had all the outpatient providers and hospitals and labs sending us data, and then we focused on severe cases and deaths because it wasn't as severe as they thought it was going to be, and there were so many cases. And then we went and focused more on the outbreaks, the healthcare workers, and the pregnant women. We also implemented a new surveillance system with the hospitals to look at aggregate hospital pneumonia and influenza admissions and deaths during that time period to get a better picture of what was going on. And we started some new school outbreak procedures so that they could report online so we could get the information faster and follow up with them faster as well. And why we do all this enhanced surveillance is to see if a novel strain comes that might become a pandemic. So right now, these are the World Health Organization pandemic phases. There's phase 1 through 3 that have new viruses in animals, and they can cause infections in humans. So with H5N1, we were up to phase 3. With the pandemic H1N1 of a couple years ago, 2009, we were up to, we were considered a full pandemic because it's based on geographic spread. So there was widespread of the pandemic H1N1. It's not based on severity. And the way these pandemics happened, I showed you this picture before of the influenza virus. You get infected, your body develops the antibodies depicted by Ys. But sometimes there's a completely new virus, an animal virus, that you don't have any antibodies to. And when there's a genetic reassortment of these viruses, so now you have a completely new virus to humans that has both human components, which might allow it to go person to person, but also has the animal components, so you have no immunity to it. And that's when you get concerned about having a pandemic. So back when we had H1N1 a couple of years ago, people were talking about swine influenza a lot. So pigs have influenza all the time. It's type A, and there's different strains circulating. They can have outbreaks as well. And then there's been triple reassortance of viruses from pigs, humans, and birds circulating in our pigs since 1998. But usually these strains do not infect humans. Previously, between 2005 and 2009, there'd been only 12 cases of human infections with swine influenza. But then, of course, our pandemic occurred in that spring. Here we have the turkeys have bird flu, the cows have mad cow disease. I'm telling you, boys, unless we want to see more ham served on Thanksgiving, we're going to have to get our own disease. So that's when we started to hear more about different swine flu. So this is actually the H1N1 pandemic virus, which is now considered a seasonal strain, because that's what happens. You have a pandemic, and then it just becomes, everyone starts getting infected, and then it starts spreading between humans and becomes a seasonal strain. So we have here a Eurasian swine virus, we have the classic swine H1N1, a human H3N2, and an avian virus. These three combined to make these two, and then this one combined with these to make this virus that became our H1N1 pandemic in 2009. I'm going to skip over these because I'm running out of time. But going back to now, this past season in the summer, we had some purple, which were the variant H3N2. So this also started as a swine strain. So this is here the swine strain H3N2 that was circulating in all our pigs. And then this is our human H1N1 pandemic strain from 2009. And notice this red gene, the M gene, which is that ion channel, that is now in this new virus, this variant H3N2, which started circulating more so in about July of last year. And so because it had that human component, there was concern that this would go person to person. It ended up, it really just stayed among the pigs, and then it affected some humans that had contact with pigs or visited fairs. There were only 16 hospitalizations, minimal person-to-person transmission, and really we haven't seen a lot of that since the fall. But with all this enhanced surveillance, we're now hearing about other variant strains. So I think this is something we're just going to keep hearing about it because we have the technology to be able to detect these, and we have the surveillance in place. So when they see a variant strain, they watch it very carefully, see if it's spreading in the people around the index case. But then if it doesn't spread anymore, we don't worry about it. But we are going to keep hearing about these variant strains. So I have here a couple copies of our newsletter, which I can leave up here, but you can get them online. I only brought a couple copies because this actually is coming out today. It hasn't been approved yet, but I doubt there'll be any changes, but you can get a look and see if you would be wanting to. You can receive it by email, or you can look online if you're interested in getting updates on influenza. In addition, our healthcare agency website has more information, as well as the newsletter. The CDC website has tons of information on all those graphs I showed you, as well as the state website for the state surveillance. And just some reminders for you guys. How many people got vaccinated? Oh, so not even half. All of you, there's time. There's still lots of flu out there. You know, you can get the shot or the nasal spray. Everyone over 6 months is supposed to be vaccinated, especially if you have high-risk conditions. On our website, you can see where free vaccine is available for you. I don't know if you can get it through are you still offering it through Student Health?
Yes, and we still have flu vaccines. You can come and make an appointment. If you have the SHIP insurance, it is covered, but it is a covered benefit. You don't pay anything.
Okay, and if you don't have that, then you can come to our clinic as well. We do provide it. And then there's also retail locations as Health Map Vaccine Finder. You just put in your zip code and it tells you where all the vaccine is near you. And just remember, cover your cough, wash your hands, and stay home when you're sick, at least 24 hours after your fever resolves without fever-reducing medications. And then, you know, especially if you're sick, clean up after you. Make sure to wipe down surfaces that are commonly touched. And really, just to summarize, you know, there's a lot of influenza surveillance that we do, and it is important because it does detect the changes in the viruses that could lead to possible pandemics. It helps us update the strains to use in the vaccine of the upcoming season. Helps us guide treatment recommendations through looking at antiviral resistance. It helps us to respond to pandemics, provide triggers of when we need to start to get worried, and then also to see who the high-risk populations are, who needs to be targeted more for messaging, and who the clinicians need to really remember to get in to come back and get treated if they do have symptoms. Here's my contact information if any of you have questions, and I'll take any questions now. I know we're running out of time.
Thank you. We do have time for a couple of questions. Well, I have one. I noticed that the paper that compared the strains and where they originated, there wasn't any reference to a virus originating from the African continent. And I was wondering if that's because of lack of data, because nobody is looking, or that in fact there wasn't really any? And the same was true for the, here.
Well, this wasn't all the viruses. This is what just their study. Yeah, it was just a sample. There is surveillance in many of the different countries, but some have stronger surveillance than others. If you look at that other graph, there is surveillance there that shows in Africa what types they have. Any other questions? Yes.
There's something in the biochemistry of the influenza virus that makes it so virulent and so.
Well, it really depends on, there's different virulence factors that all viruses have, but sometimes we have a mild year, sometimes we don't, and that's all still under study. They think that some of the surface proteins do play a role in that, but once again, it really depends. You couldn't tell and just say, oh, that virus is going to be bad because it has this on it. It's really every year you kind of see what's circulating, and that's why the surveillance is important, to see what's really happening with the viruses that are circulating that year. Yes?
So currently all the virus diagnostic or surveillance is through the blood-based diagnostic. Is it possible to detect these viral particles in aerosol?
Oh, so this is all through respiratory specimens, all this data. I'm sorry, I didn't mention that. So it's usually nasal pharyngeal swabs or sometimes a combination of nasal and throat swabs. Yeah, none of this data is through blood.
How about from the aerosol particle from the atmosphere?
They don't do that except in studies to look at whether or not there is aerosol transmission. So, because of healthcare isolation and infection control, they have tried to look at whether or not you should use a surgical mask or an N95 mask. So they've done those kind of studies looking at the particles, but it's not part of routine surveillance to do that. Any other questions? Thank you.
Okay, thank you very much. We have a little